this is. But my perspective is that, I'm a big fan of orals. If the patient can tolerate it, I would avoid topical acyclovir, ganciclovir, because of the ocular toxicity. Naturally, follow-up comes into play, right? Because we have to follow these patients, but oral acyclovir 400 milligrams 5 times a day, or valacyclovir 1000 milligrams 3 times a day is my go-to for these patients. And lubrication, autologous serum tears, punctal plug therapy, so that the patients can actually keep their tears on their surface and they can actually see better. It's masking any astigmatism that's coming up because of corneal scarring. But I have realized that I always get pre-screening of BUN, creatinine, and liver function tests. I've recently had a case where it was rare, but the patient had developed kidney failure because of this, right? And so, though rare, we have to be very careful. And if it's a child, or if it's someone who has any systemic illnesses, or have any other issues that we need to think about. I had a patient who was from Hong Kong that came to see me, Down syndrome patient, right? Didn't have a kidney problem beforehand, but this is that patient that developed renal toxicity. And so we have to be very, very careful. And so from now on, after that, I make sure that there's a screening of these blood tests. But in addition to that, I always get an MD clearance, make sure that the patient is cleared to undergo this treatment. Before that, I would say I have never had to. I always say that this is the most safest thing to do. But when you see it once, you definitely don't want it to happen again. Okay. Oral acyclovir, so what are the side effects? Nausea, vomiting, diarrhea, bradycardia, hypotension, okay? And then kidney failure, because though rare, it does happen. And it is because acyclovir is excreted through the kidneys, okay? Oral valacyclovir, 1000 milligrams 3 times a day. As we all know, after absorption, it is converted to acyclovir by the liver. So valacyclovir has a liver connection there. It is then metabolized intracellularly in viral infected cells and then largely excreted by the kidneys. Common side effects here, though: depression, depressive symptoms, feeling sad, lack of concentration, irritability, lack of appetite. So these are all things that we need to counsel the patients on. Thrombocytopenia, increased heart rate, increase in blood pressure, okay? Kind of the opposite of acyclovir. And the rare risk of kidney failure. Rarely has it ever been, I've never seen a case report of valacyclovir causing liver, but I still get the liver function test because of its clear pathophysiology of valacyclovir being metabolized and converted to acyclovir by the liver. Topical antivirals, as I said, it is my last resort. I'd prefer not to do that if I could, because of the ocular surface toxicity. We're trying to smooth over the epithelium, and here we are going about it by creating a toxicity. Similar to if we say acanthamoeba, right? Acanthamoeba keratitis, how do we treat it? We treat it with bleach cleaners, right? PHMB, chlorhexidine. Everything that is toxic, we're throwing it on the cornea, hoping for Broline, all of these, so that we can be able to help the patient. But if we can help the patient with something that has, generally speaking, minimal side effect risk, I would go for the orals. Now, I've just told you so much about how a patient can develop liver and kidney toxicity, but that was 1 in thousands. So it's important to see the bigger picture. And in this case, in every case, I prefer always starting a patient on orals before going to topicals. But if there are abnormal lab tests, if there's a cardiac issue, if the patients have any reason why we cannot start orals, if they're lost to follow-up risks, what have you, then I would do topical antivirals, okay, topical ganciclovir. I was told by Dr. Menen that you have topical acyclovir 3%, but always adjuncting it with lubrication. And like I said, my go-to is autologous serum tears. So I'm very curious about the Ethiopian context. I really do want to know more in detail from you as to what is available, what is not available. But I think that overall, there are so many aspects to this that is case dependent. Epithelial debridement, when would you do it? When would you not? I find that it is my last resort. I would try a patient first on oral antivirals. I would say that let us try that for at least 14 days. And then if we're still finding that the patient has a classic dendrite or pseudodendrite, and we're not finding that there is any resolution to it, at that point, I would then consider it. And very important is that once you get the patient quiet, I have seen so many cases where I tell the patient, please, 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 you are now out of the blue. You are now cured for the moment. Please start acyclovir 400 milligrams twice a day. Please start 400 milligrams acyclovir twice a day. And they do it for 2 months. And guess what? They are with me on month 3 because they stopped it, right? So I have realized that acyclovir 400 milligrams twice a day in prophylaxis is critical, and other doctors that are working with you systemically for this patient, suppose the rheumatologist, right, is working with you. The fact of the matter is they're not going to really understand why this patient is on long-term oral acyclovir. So you really need to build your team of specialists, and you need to talk to them. You need to counsel them. You need to speak to them your language, because they don't understand what you're seeing in the eye. They don't understand what's going on systemically. They think that, oh, systemically the patient is fine sometimes. But the fact is that the more you have to dig and be with the rheumatologist. I've told Dr. Rebecca that how great would it be if we had an interspecialty clinic with a rheumatologist there and the cornea specialist, right? And the immunosuppression team, if it's not the rheumatologist, it sometimes is the dermatologist, but really so that they can see what it is that they otherwise would not be able to see if you just send the patient to their clinic. They will not understand what's going on. And sometimes it's only the eye that shows up and nothing else. But by digging, by them understanding what's going on, they then start to realize the importance of doing a complete systemic workup for immunosuppression. And that's how you find things. But they have to be on your side. Otherwise, they're not convinced by a red eye that looks like viral conjunctivitis that'll go away next week. So they don't understand that this is different. This is not a pink eye. And so I definitely encourage collaboration across the board with this condition. And with that, I will open it up for discussion and questions. And I thank you very much for the opportunity to be with you all. And just I've made so many great friends and colleagues from Ethiopia, and just looking forward to many more opportunities to be with all of you. Thank you. Dr. Menen, over to you.
Now, thank you, Dr. Nariani, for the very nice presentation. I loved it, and I was like, is this all? Because it was very interesting. Like you finished it and before I knew it. So, anyways, I have uh, maybe a question would be like uh, the COVID-19 thing. How would you know if someone is having like a corneal viral infection from COVID-19? Is there a specific test for it, or are the signs typical for it, be it from the infection itself or from the vaccination? Is there like a diagnostic thing for it? That's a question. But for the other comments is the epithelial keratitis. All of us, probably my friends here and myself, we see so many cases of epithelial herpetic keratitis. Uh, for me, probably almost every day. The challenge I have in those cases is uh, uh, you probably will not have a similar problem, but for most of us, I feel like it's very difficult to find fluorescein dye to stain the cornea. So I have nowadays a headache seeing so many patients having herpes keratitis, but have been treated with steroids because there has not been proper use of probably fluorescein. So I would advise everyone to like use fluorescein in each of the cases. And in the absence of fluorescein, it would be nice to make a very careful exam of patients who would come to us with like signs of red eye, foreign body sensation, tearing, because those patients, because they complain like foreign body sensation are kind of itching tendencies, like to like have a glance at the cornea and say that's a kind of allergic conjunctivitis and treat them with steroids, and they end up having a huge dendrite or a geographic ulcer, which is very difficult to clear with the a cyclovir ointment or even the PO that we normally use. So I would ask everyone to please use fluorescein as much as possible in examining the cornea in general whenever available. Otherwise, please let's all be careful to examine the cornea carefully, not to miss any viral keratitis in its early stages. The autologous serum, we
No,
have
Dr.
never.
Menen,
Okay.
Dr. Menen, I find it so interesting that you brought up that fluorescein is not available, because that is the mainstay of
Yeah.
of our identification of epithelial keratitis.
Hmm. Yeah, but it's not readily available in the country, so we might be able to get it in medical schools where we have residents. But I don't know if we do have it in other hospitals and as well as private setups. I know most of us try to buy it from our own pocket, but I think that's something that we have to continue to do in order to be able to like not to miss any epithelial keratitis. Because I get patients treated with Dexa or other steroids, and then it's very difficult to heal it, be it with topical or PO.
I find
So
that so interesting. I find that
yeah.
so interesting. But I would ask you, Dr. Menon, when you don't have fluorescein, how do you then pick up on epithelial keratitis?
There were times when I have picked early dendrites with just diffuse illumination of the slit lamp without using fluorescein. But of course, I usually get fluorescein. I don't have that issue. It's not very difficult if you very well scrutinize the cornea, but you need to give it time and look at it very carefully, and there needs to be a high index of suspicion as well. So if you look for it, you see it. But in order to be able to appreciate it very well, yes, of course, you need the fluorescein. Otherwise, if you're suspicious you don't have fluorescein, then it's better to like send the patient to a place where fluorescein is available. At
Absolutely.
least in Addis. At least
Absolutely.
in Addis.
Absolutely. I mean, I will tell you, when I moved to India, I moved to India from the United States full time 5 years ago, and I started working at a government municipal hospital for the underserved. Um, I will tell you that patients are very, whether they can afford or cannot, let's be honest, they all want phone consultations, right? And distances are such that they will call me that they're in another state, right?
Mhm,
And they can't come and they have a red eye. And what do? Family members, naturally, everyone will call, right? And I have
mhm,
been burned by someone who has a very strong immune system, no underlying issues, and I treated the patient over the phone,
mhm,
topical steroids. And basically after that, the patient came in, and the eye got worse, and naturally we're
mhm,
dendrite. So I would encourage everyone here to realize, and you all know it better than I do, that ultimately don't take a red eye and just start treating it with topical steroids. If
mhm,
you get burnt with that, then you will lose the patient, you will make the patient go blind. So please know what you're treating before you start treating it. And if it is epithelial keratitis, then identifying that and ruling it out is a critical foundation. I'm glad you told me, Dr. Menen, that we don't have fluorescein, because at least in the temporary, there are temporary fixes for us to know what is required, so that we can help out. Thank you for sharing that.
yeah. Yeah. So the other thing is, it's not only that patients go to like ophthalmologist and not the dendrite will be missed by not using fluorescein, but most of our patients also go to pharmacies, and there is a chance that they might also be given steroids instead of like the right treatment, because they complain like they are having red eye, foreign body sensation, and so on. So there are also times where they get it from pharmacies as well. So that also needs to be communicated to the pharmacists who would give patients steroids without prescriptions. The second point is the autologous serum. Uh, Autologous serum is not yet available here. Probably this is one step ahead for probably the Eye Bank of Ethiopia, now that it's working with the blood and tissue bank. It has been renamed like blood and tissue bank, and people working at the blood bank were like suggesting that we prepare autologous serum. So that would probably be the way forward, because we know the type of tear again that we have is mostly not preservative free. So we know that it will be toxic when we use it like for more than 4 or 5 times per day. So again, that's something to think of. And thank you for sharing your experience with the autologous serum. Um, Regarding the
I
PO,
have found, Dr. Menon, remarkable changes. I've been shocked by how patients have been completely soothed over because of it. They've gone to, I can't tell you how many doctors, and then um they stop at my hospital. We see the patient. We do everything that everyone else does: the topical steroids, the topical antibiotics, the orals. I'm seeing here that oral acyclovir is not available, but in the Ethiopian market. But we do all of that. But what is the clutch is, how do we prevent recurrence? And
yeah,
that has been a game changer for me.
mhm, okay, yeah. Regarding the use of the topical versus the oral, when it's like dendritic ulcer, where you need to treat it like for probably 7 to 10 days, I still use the topical instead of the PO, but would not use it beyond 10 days to avoid toxicity, unless this is a patient where the patient had, for example, a kidney transplant. You don't want to give them PO steroid, PO acyclovir there. So I have a patient post-kidney transplant, but with a very recurrent herpetic keratitis where I'm forced to like use the topical acyclovir. So what I do is just but try to balance the steroid and the topical acyclovir, probably do it like once a day instead of multiple times because the patient still needs to use the topical steroid. So it's unless it is for such cases, then we would use the PO acyclovir when I have to use it for a longer period of time, especially for prophylactic cases.
For that, then does that patient have epithelial keratitis? The kidney
This patient, no. I'm also giving him tears. Fortunately, this is a guy who could get preservative-free tears from abroad. He has relatives who can send that to him. So he is using that frequently. So far, he's fine. But the moment we stop the steroid, the problem is he starts to have stromal reactivation. So I couldn't stop it. And for fear of like having epithelial, I would just add the topical. But as I said, I don't know if that is really helping in preventing the recurrence of or the reactivation of epithelial keratitis.
This patient has had a kidney transplant, you said?
Yes, he has had a kidney transplant. So I did not want to give him PO acyclovir.
So I wonder whether that immunosuppression, I mean, granted the immunosuppression will may reactivate it, but to some extent, right? Oral steroids, right? We cannot do oral steroids here or anything like that.
No.
But I wonder how that immunosuppression is interacting with the eye. Do you notice that when they increase or decrease the immunosuppression for that patient, whether it reactivates or how the eye responds?
So the kind of immunosuppression that he gets has been the control is done by the guys who are looking at his kidney. So I don't think there is any change in the dose of the immunosuppression that he's getting. But that's something that probably I may have to ask for. But the moment I try to withdraw the steroid, he tends to flare up with the keratitis.
Yes, yes.
Yeah. So one other probably final point I have, and then would give the floor to my friends, would be I find it very helpful to like inform patients about their condition. If I treat a patient with herpetic keratitis, I'll tell them that they have a disease which is caused by a virus at least. So in case I'm not the one who sees them the next time they have the recurrence, they will tell their doctor and get the right type of treatment. And also they will not be given like probably steroids or some sort of immunosuppressants that would lead to reactivation of their disease. So involving the patient in the management of the disease has been very helpful for me in managing especially patients with recurrent diseases.
Agreed, agreed. These are the patients that sometimes take the most amount of time because they have to know that complications can occur from their treatment. They have to know that this back. It is not a reflection on the doctor that it comes back, right? And I also believe that taking holistic measures when possible, right? When we're talking about the farmers that come in to see us and villagers, they are hand to mouth. They don't necessarily have the ability to pay for their medicines, but sometimes also be able to take a day off, right? The stressors in life. But when the luxury of living a more stress-free life can occur, I have noticed that you change holistic measures. right? Reducing the stress when stress doesn't have to. A patient who is a truck driver and has to drive overnight, and then the next day, every time they pull an all-nighter, they develop a keratitis. Well,
Mhm.
that's the reason for their problem, right?
Yeah.
So if we can switch their job, right? Sometimes nobody wants to switch their job, but my point is identifying the triggers, reducing stress when
Mhm.
possible, identifying the underlying cause. All of this will save a patient's life forever because they'll be able to actually open their eyes. They'll be able to see because you've identified just beyond the realm of their eye, you've realized systemically what's going on, you've realized lifestyle what's going on, and taking intervention. So yes, these patients take a while, but they become your patients for life.
Yeah, that's true.
And
So now,
I
if
just have a question about COVID-19.
mhm, I was to remind you about that. Yeah.
So with COVID-19, Dr. Menen, I have noticed that there is no particular telltale when it comes to the keratitis or anterior uveitis or beyond. The COVID-19 can affect any part of the eye.
Mhm.
Mucormycosis, we saw over 100 patients with COVID-19 associated mucormycosis requiring patients, some of them requiring exenteration and all of that. COVID-19 can affect any part of the cornea, any part of the eye. And so the key factor is the timeline, the history, knowing
Mhm.
that the patient had the vaccine and then this happened. It's hard
Mhm.
because sometimes there's many factors that sometimes are confounded. Oh, this was also started, and this was also started, and this was also started. But
Mhm.
there has to be a clear sequential timeline that is identified to then say, yep, this is the etiology of it.
Okay. So thank you. Then now probably we would like you to comment on all the uh, questions that were raised in the chat box.
Yeah.
Should I read them for you, or can you?
No, I'd be happy to, Dr. Menon. So I had a private message come to me. Would you recommend starting prophylaxis with PO acyclovir after a single first attack of epithelial keratitis that resolved with therapeutic systemic topical meds? Great question. So basically, would we start prophylaxis after a single attack? And my answer is, it depends. If the patient has epithelial keratitis, and then I will always do when I see a dendritic ulcer or what have you, identify what is the underlying cause. What is that underlying cause? I will send the patient to the rheumatologist or the general family doctor, and I will have a systemic workup done because what is the cause, right? Why does this patient have what they have? And if, in fact, I'm still not able to identify what the cause is, I would say that, all right, there's no current identification. Maybe it's a stressor in your life. And so let's try and see if we can do lifestyle changes. If it happens a second time, that's it. 2 strikes and you have 1 oral acyclovir prevention. But I don't necessarily take it as the first hit because it could be that there is a current, lifestyle interruption that has led to this. But if it's a recurrent thing after the second time around, yes. The second aspect of it, it depends on how severe it is, depends on how classic it is, right? So if we're talking about it being, we're not sure, is this in fact herpes? Is this not herpes? Again, I'll watch and wait. But if I'm seeing the dendrites, I'm seeing the pseudodendrites, right? We know what the studies have shown. If it's so classic, then yes, absolutely go ahead and do it the first time around. Thirdly, if there is an immunocompromised condition like lupus, HIV, AIDS, all right, then and the patient can be cleared to tolerate oral acyclovir, then yes, in those cases, whether there's a clear-cut etiology, I would start it twice a day in the recurrent areas, because we know that there's a clear-cut etiology. Now, if with treatment, sometimes we cornea specialists, Dr. Menen can speak to this, are the first ones to diagnose the patient to have lupus or to have any systemic underlying condition, because we see the herpes in the eye, right? And in those cases, those patients are not yet on oral treatments for that. They're not on the oral immunosuppression. So in those cases, I need that to be controlled off, stabilized, the immune system strong, and then we will consider relieving it, maybe. But if the patient can tolerate it, like I said, side effect profile is there. As long as the patient is counseled about it, as long as the patient has normal BUN creatinine and LFTs, I go ahead and I will do it for a year. Repeat those labs in about 4 months, every 4 months, once a quarter. The next question is, once epithelium is fully healed, how soon do you, Dr. Menen, how would you do it differently
No, you
regarding
can
that?
go ahead. No problem. You can go ahead. You mean the...
For the first attack, would you do anything different?
No, that's how I treat it. Usually I don't even use the pure cyclovir. As I said, I use a topical, and then just follow them. It's only if they have a second attack that I would recommend using the prophylaxis, as you said.
The next question on the chat is, once epithelium is healed fully, how soon do you start topical steroids, and for how long do you give it for? Right? So good question. Question back to you is it just epithelial keratitis, or is there also stromal keratitis, right? Is there anterior uveitis? What else is going on in the picture of this patient? If the patient just has epithelial keratitis, right, and it's fully healed off, then that's fine. But likely these patients are also going to have your stromal keratitis. And that is the case. If that is the case, I would definitely say, as soon as my epithelium is fully healed, I blink an eye, blink a day, and the next day the patient is on topical steroids. I hope that answers your question. Oral acyclovir is not available in the Ethiopian market recently. Is that a new thing, Dr. Menen?
Now it is available. Probably the brand is different. Otherwise, it's available.
Okay. And do you have valacyclovir also?
No, it's only acyclovir.
Only acyclovir. Okay.
Mm-hmm.
If you had the choice of having valacyclovir versus acyclovir, any preference? I know some will say that 1,000 milligrams 3 times a day, as opposed to acyclovir 400 milligrams 5 times a day, is a lot easier for a patient to take. Do you have any particular preference, or happy with the way it is with oral acyclovir?
I think I'm happy with the oral acyclovir as it is for now.
The next,
Especially as a prophylaxis, because we usually give them only twice.
yes.
I don't think I have seen any lack of compliance when it comes to like twice a day dose.
And that's the interesting thing, right? Is that with acyclovir, studies have shown 400 milligrams twice a day. It is so clear cut that they had to shut down that study, that leg of the study, because it was unethical to keep patients away from prophylaxis. So those patients that did not even get the acyclovir 400 milligrams twice a day, they had to say this is unethical for them. They're getting so many recurrences because we don't have. They shut down the study. So the fact of the matter is that oral acyclovir has been shown, but valacyclovir, I haven't seen a study out there that has shown the dosing for valacyclovir. So when we know what works, then we surely should go with it.
Yeah.
The next question is, for patients on oral acyclovir prophylaxis for more than a year, when do you discontinue? My second question is, patients who are on oral prophylaxis and have discontinued on their own, when would you decide to reinitiate or just to follow without prophylaxis? Great question. So the first question is, for patients on oral acyclovir prophylaxis for more than a year, when do you discontinue? Well, studies have not shown that after a year, what do you do? But I have found that if the patient is happy on it, there's no side effects. I'm ongoingly every quarter checking their BUN, creatinine, and liver function tests, and everything is fine. I continue it, because what happens is that these patients can have blindness, right? Blindness and visual impairment. If we can do it with something that relatively has minimal side effect profile risk, side effects are there, but the risk to a patient are minimal, then why not? After a year, I would continue on. Dr. Menen?
Yeah, same here.
Perfect. And then I love this second question. My second question is, patients who are on oral prophylaxis and have discontinued on their own, when would you decide to reinitiate or just to follow without prophylaxis? I have had those patients. I have had
Me
those
too.
patients, right?
Yeah, me too. Yeah.
Right? And they come on their own back to you because they're like, oh, my eye is red, right?
Mhm.
So the fact of the matter is if they choose to stop it, who are we? We can do the best counseling we can. We can tell the patients, you know what, this is the best for you. But if they've stopped it and they're not following up with you, they will come back on their own to tell you that now I have a red eye. And that's when you'll counsel them again that, look, the reason why you have a red eye is because we stopped this. So you don't have to reinitiate. If they come back to you and they're happy, fine. But the point is that it is so minimal a side effect profile that they should understand. They should be taught that it's unethical. Studies, it's unethical, actually. Just imagine. I've never in any other eye disease study, of any eye condition in the literature seen anything be as stagnant a change as to have to shut down a study because it was so monumental that twice a day dosing helps. So if you see a patient, they've stopped it, I would not hesitate to go back into it, but like I said, they'll probably come back to you.
Yeah, if they come with a reactivation, yes. But what if they are okay? They have stopped it and they are okay. Then you let them without the drug, right?
Yeah,
If they don't have any.
yes, you're absolutely right. They are part of your family now, right? So it's a communication. They have their own feeling. They've stopped it for some reason. Sometimes it's a cost issue, right? So we have to look at it from the socioeconomic and from the global standpoint. And in that case, if a patient has stopped it, understanding why they've stopped it, right? Understanding if there's a cultural barrier to being on medicine for that long, or if there's a cost issue, right? And then just being on their side, being their champion to say, I get it. Cost is a lot. Fine, let's watch you closely. I'm here whenever you need me, but understand that by stopping it, if you do ever get a red eye, don't just treat it by yourself. It could be just the same thing coming back, and so come in. So I think there's never a clear cut black or white. It just depends upon the patient's situation too.
Yeah.
The next question is, do we have always to initiate topical steroid for epithelial keratitis in addition to the antiviral? Dr. Menen, what do you feel about that? Because that is a very controversial topic for sure.
Do we have always to initiate topical
Topical steroids
for
for
epithelial?
keratitis.
No, it's not always at least.
Some,
You,
yeah, no, please go ahead, Dr. Menon.
if it's simply epithelial keratitis, it goes away, it heals with the topical or the PO acyclovir that we have treated them with. I don't see a reason to initiate topical unless we have involvement of the stroma. There are times when I see patients, for example, with what looks like disciform keratitis, endothelitis, that has been there for a long period of time, not treated in time. Patients probably develop involvement of the epithelium, they come ulcerated. Those cases, I treat them, and then when the epithelium heals, then that would be a time when I would start topical steroids with PO, acyclovir, prophylaxis to clear initially treatment dose and then prophylaxis to clear the endothelitis as well. Otherwise, or there could as well be stromal as well as epithelial sometimes. I have seen it in some cases. So I would treat the epithelial keratitis and then put them on initially low dose steroid. And as it keeps on clearing, I may increase on the dose of the steroid until the stroma gets clear. There would be times I do that. Otherwise, if it's simply epithelial keratitis, I don't remember a time when I have used steroid.
Yes, perfect. Yeah. So some surgeons are actually going to say, oh, you know what? Let's also start up topical steroids, especially if you have epithelial keratitis in conjunction with stromal
Trauma.
keratitis and
Yeah.
anterior uveitis. So this becomes a very controversial issue because you say, oh, well, you're going to cut some of that scarring or you're going to cut some of that anterior uveitis inflammation. So give it to them. I'm pretty clear that if it's epithelial keratitis alone, there should be no evidence or need for topical steroids in those cases. Now, if you have epithelial keratitis combined with stromal keratitis or herpetic anterior uveitis, let us get rid of the problem. Like I said, 2 weeks, get them on treatment. If you can do oral acyclovir, do oral acyclovir. If you have to, topicals, fine. Antivirals, fine. But after 2 weeks, if they are still not healing up and you're dealing with stromal keratitis and anterior uveitis, I would then go to an epithelial debridement, get rid of the problem, put a bandaged contact lens on it, get the epithelium to heal over with lubrication, 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 be aggressive on that, and then get the patient started on steroids after that. One problem at a time is the best way to go, in my opinion, when it comes to epithelial keratitis combined with multiple layers of cornea involved.
Yeah.
Can you further elaborate on how to prepare, store, and patient use of autologous serum tears? That's a great question. I feel like that should be its own topic altogether because it's such an interesting one. But autologous serum tears, we're very lucky that the eye banks here, I would say I'm probably even in the realm of cornea, just imagine I am the corneal surgeon that they know is going to be the one calling for autologous serum tears. So I've had extensive communications with my iBank team members, have that ongoing communication and constant friendship with them because they're going to be the ones to go to bat for you. The centrifuge is kept there, okay? You draw up their blood, whatever amount comes, 1 vial, 2 vials, we centrifuge it down, dilute it down, okay? And then identifying the platelets, identifying the nutrients, we then separate it out. And that centrifuge is what is used to do that. And then we dilute it down. Either I choose a 25% concentration, or if it's a severe, say, Stevens-Johnson's patient, extreme chemical burn, then I'm looking at 50% concentration of autologous serum. And then we use a 10 ml bottle for the to place it in. We remove the artificial tears or what have you in the bottle. Keep it to 50% concentration or 25% concentration. And whatever bottles we get out of it, great. One bottle I tell them to keep in the fridge. Suppose I get 3 vials from a patient, the other 2 vials go in the freezer. And when one is done from the fridge, then the patient will switch over from freezer to fridge. So in that sense, it can last for as long as you want, as long as it is kept frozen, and for the ones that are not being used. So that's the key there. Okay, but yes, it is something that probably takes a little bit of a mini workshop to understand the step-by-step of how to do it. I'd be happy to, or I'd be happy to get the iBank that works with me also involved in that, because I think that they're the ones I lean on to get that done for us. And now they've been a pretty much an expert. But when I come, Dr. Menen, I'd love to see that system set up at the iBank Association here in the iBank of Ethiopia. It would be really a great next step forward. I'd love that, and I'd love to help in any way I can.
Okay, thank you.
The next question is, would you recommend starting prophylaxis PO acyclovir after a single attack? That resolved with therapeutic systemic topical meds. I think we answered that, if I'm not mistaken.
Yeah, we did.
And then the next question is, what about the role of oral acyclovir in the treatment of herpetic endotheliitis and herpetic iridocyclitis? Excellent question. It is essential that we know that oral acyclovir decreased the risk by 45% of ocular complications of recurrence across all ocular complications. Underline all, bold all. So even in endotheliitis and iridocyclitis, the rate of recurrence is minimized when you have the patient on it for prophylaxis. As far as treatment is concerned, absolutely. Keeping the patient on 400 milligrams 5 times a day for endotheliitis as well as herpetic iridocyclitis is my mainstay of practice as well. Now, the trick is that you know what you're dealing with, right? Endotheliitis, iridocyclitis, if you're dealing with, say, just an iritis where the patient has a nuclear fragment there, and the patient has this non-specific, I was running a case, there's a case in Ethiopia about a sectorial corneal edema. I was talking to one of our esteemed colleagues about that case, right? If there is sectorial corneal edema and we're thinking, oh, okay, you know what, could this be herpes? Could this not be, right? The fact of the matter is could it be something else, like a nuclear fragment, right? That needs to be addressed. First, identify that. The difficulty is with herpes is that apart from the classic dendrite or pseudodendrite, the facial lesions when it comes to varicella zoster, sometimes it's very difficult to diagnose, right? So are you dealing with a herpetic endotheliitis or something else? Are you dealing with a herpetic iridocyclitis or something else? If you're sure that it is indeed herpetic in nature, then go for oral acyclovir in your regimen. Dr. Menen, would you do anything differently?
No, I think it's pretty much the same.
Perfect. So Dr. Adisu, my friend, has written, is there any specific remark you want to tell us on the management of herpes simplex virus keratitis in the pediatric population? Absolutely. Dr. Adisu, you can probably tell us about how to do that. But I think what's very important is that, all right, we have to do it dose dependent, right? Weight-based. So if you do have access to oral antivirals, you definitely have to make sure that you run it by a pediatrician and make sure that the patient is safe to be able to start on oral acyclovir or valacyclovir, and reduce it dose dependent. The other thing too is, just like my adults, I would check BUN, creatinine, and all of that. But even more importantly, for the management of the kids, right? With Dr. Adisu, we have to make sure if it's a child that has herpetic keratitis, my first, second, and third question is, what is the cause? Why does a child have herpetic keratitis to begin with, right? And so even more importantly, though it's my standard regimen, even more importantly, for my kids, I am very attuned to what is the cause, what is the cause. I will not sleep till I find out what that cause is, and then identify that and treat it. Dr. Menen, would you do anything differently?
There are times when the kids won't be able to, like, especially for the PO acyclovir, we have the syrup acyclovir. So if anyone would like to use the acyclovir for kids who are not able to take the tablet or the capsule, then they can use the PO syrup whenever they want to. There are kids also who are very difficult to apply ointment. So instead of taking the topical like 5 times, probably they can take the syrup 5 times a day, calculated on their weight.
That is great, Dr. Menen. And is there a lack of access or shortage at all of that, or is that pretty well stocked in the country?
Until now, I don't have a problem of getting PO syrup, acyclovir for kids. It's still available. I'm not sure. I do have few patients.
Yes. Would you, I'm curious, ever admit these patients, given the fact that you can then do, say, an IV dose or anything like that? Would that be for kids, especially knowing how blinding the potential is? Would you
Yeah.
ever admit the patients?
I have never done it. Probably the youngest I got was a 3-month-old child. So I just, communicated with the parents very well. They were very cooperative. So I never admitted a kid for herpetic keratitis management. They all were managed at home, and they all did very well.
Superb.
Probably it could be because they are from the city and parents were well aware. That could be the reason, but I've never admitted a kid for IV treatment.
I had worked at a government municipal hospital for a number of years here in India, and over there we had the luxury that patients would pay less than $3 for admission, and so we had the benefit of being able to follow these patients and have them watched under our clock. So it's a unique situation, but I have found that non-compliance in a child and the amblyopia development to be difficult. Naturally, we get these cases, Dr. Adisu, rarely, but when we do get it, if we can just keep them under close watch because of the risk of amblyopia, I would. But naturally, that is a luxury for having the opportunity to admit patients freely like that. But I have seen it where patients can go from a corneal opacity to stromal keratitis to perforation quite fast. And if there's any potential that a patient is not going to be compliant or follow up, and it's a child we're talking about, then the closer the watch, the better. So another question that I see here is, it is relatively common to see recurrent herpetic keratitis in children. Do you recommend treating them with the same adult principles as adults? Okay, I think we went through some of that right now. How do you see the benefit of adding lubricant eye drops autologous on top of acyclovir ointment? Because the topical acyclovir is in the ointment preparation with long contact time and frequent dosing. Very good question. So once you get access to the autologous, so again, my standard of care when possible, of course, every patient is case dependent, but my general go-to is to do autologous serum tears for epithelial keratitis, and oral antivirals, not acyclovir or ganciclovir ointment. So I can't really speak to this because I tend to avoid using the ointments or gels because I do have access to the oral antivirals. However, when you are faced with the challenge that you can't use orals or you don't have access to orals, and what you do have access to is topicals, then it's as simple as having to space it out. So if you're using the acyclovir 5 times a day, that's fine. But yes, you have to just maintain that schedule of having a gap. So if suppose you're doing the topical acyclovir ointment, breakfast, lunch, dinner, bedtime, and tea time, then you just have to tell them that between lunch and dinner, at between your breakfast and lunch, equidistant every 2 hours, space it out so that you are doing it alternating every 2 hours, either the oral acyclovir and then 2 hours later autologous serum tears, and then 2 hours later oral acyclovir, topical acyclovir again, and then another 2 hours autologous. So I think you just have to be smart about of spacing out so that the autologous serum tears works first. And remember that if you start your day, try and start your day with the oral, the autologous serum tears above, because the ointment is just going to prevent penetration for sure. You're absolutely right, but a schedule is key. Dr. Menon?
Yes. Well, I have not had the chance to use autologous serum, but instead would use tears.
Yes.
So would probably do it the same way.
Perfect. And I
Yeah.
see one last question here. How do you manage epithelial keratitis in a post-PKP patient? Do you totally stop steroid or reduce the dose? Dagma Wheat, thank you so much for the question. It's nice to be with you. My question is how much post-op,
Mm,
right? Are we
yeah.
talking about a patient that is post-op day 1 or post-op week 1, post-op month 1, post-op year 1? That's going to make a difference to what we're talking about here. And then the second question is, are we dealing with epithelial keratitis alone, or are we dealing with epithelial keratitis combined with stromal keratitis and anterior uveitis and so forth? So all of those factors, Dagma, are going to impact the decision making here. Clearly, the longer post-op the patient is and the more stable the patient is, and then an epithelial keratitis is there, then you're more likely to feel comfortable. If the patient is now tapered to say once a day on steroids, you're more likely to feel comfortable of stopping it temporarily while the epithelial keratitis is under control. But in these cases, I would say I would definitely want to ensure that again, I go back to lubrication, lubrication, right? And identifying the source of the problem. And once you get the patient started on oral acyclovir, get the patient on it twice a day. Once the grafts get impacted with herpes, it is a vicious cycle. It is so, it can be difficult. So aggressive lubrication, oral antivirals, prevention, but like I said, it all depends upon where you are in the postoperative period on that topical steroid. But you have to balance the two. With herpes in general, it's a balancing act between oral antivirals and steroids, and so it's a case by case basis. Dr. Menon? Over.
Yes. Okay. Thank you very much, Ashiyana, for this great talk. It was great listening to you. It's very interesting. I'm sure we would have lots of questions because this is a day-to-day incident for all of us. Most of the ophthalmologists probably would see herpes very frequently. So it was very, very interesting, very helpful. So thank you so much. I'm sure most of us would like to have a similar kind of talk on another topic very soon, if you have the time. Thank you very much on behalf of OSC and all the group. For all attendants, there is a quiz that is sent out to you. If you can fill up that and return it, that would be great. They're asking to do the quiz now. Thank you so much, Ashiyana.
Dr. Menen, it is such an honor to share the platform with you. You have a vast number of years of experience and with, like I said, resources that you have to be so creative on. And I look forward to being with all of you in about a month, where I can learn from you and we can share experiences on patients in the clinic itself. So thank you for this opportunity. Thank you, OSC. Dr. Meseret, Dr. Sadeke, and the whole team for the kind invitation and for adjusting your schedule to be with me today.
Thank you, Dr. Ashiyana. We're very much grateful on behalf of OSC for being available in short notice. We hope to have you probably more and more frequently in the future. And we are grateful for your service, both clinically and in this teaching activity. Thank you very much. And we look forward to see you in 1 month or some time soon. Thank you very much. So everyone, we have a quiz posted here. Please, that will help us, give you CPD pointers based on your performance. Don't forget to answer those few questions. Thank you very much.
Dr. Meseret, thank you. And just to plug in for the opportunity for everyone, the research grant award applications are out by HCP. And the deadline is March 1st for faculty at affiliate academic institutions, $10,000 faculty grants for the winner. And for those of the residents that are here with us, there are $2,000 grants for residents in the virtual classroom, which would be all 7 of our residency programs in the country are part of the HCP virtual classroom. And so all residents of the country inherently are eligible for the grant. We hope that Ethiopia, we're rooting for you, that you continue to shine in that realm. And so please feel free to take advantage. It is on our website, cureblindness.org/research.